On behalf of the federal agencies who support the Focus on Aging Federal Partners webinar series, including ACL, CDC, HRSA, and NIA, I'd like to welcome you to today's panel on social isolation and loneliness. Of course, this is a critical topic, and that's amply reflected in the almost 2,700 individuals who registered for this webinar. So thanks for being here. Our objectives today, if we can move to the next slide. Today, our panelists will explore how social isolation and loneliness affect the health and well-being of older adults, discuss unique challenges associated with the COVID-19 pandemic, and provide resources to address these issues. The webinar will also address social isolation and loneliness in the context of Alzheimer's disease and related dementias, emphasize the impact and importance of health disparities, and provide information on the latest research on potential interventions and mitigating technologies for social isolation and loneliness. We are privileged to have a distinguished group of speakers on our panel, whom I'll introduce now in order of their presentations. First, we have Louise Hockley, Senior Research Scientist with NORC at the University of Chicago. We'll have a joint presentation from Ashwin Kotwal, the Assistant Professor of Geriatrics, and Carla Perissinotto, Associate Chief for Geriatrics Clinical Programs at UCSF. They will be followed by Sharia Robinson-Lane, who's an Assistant Professor at the University of Michigan School of Nursing. Donald R. Smith, the Director of the Area Agency on Aging of Tarrant County. And we'll round out with Hiroko Dodge, who's Professor of Neurology at Oregon Health and Science University. After the panel discussants, we'll also be having a 25-minute question and answer period. We had over 100 questions come in through our registration site, and we think many of those will be answered by our speakers in their presentations. However, if you have additional questions, you can submit those to our webinar coordinators in real time, and we'll try to answer as many questions as possible during the Q&A. So to submit a question, please just click on the live feedback button at the bottom of your videocast page. So we'll now start the panel presentations with Louise Hockley. Thank you.
Just wanted to thank everyone. I'm pleased to be part of this panel of experts on social isolation and loneliness, and I want to start by defining our terms. Loneliness and social isolation are related, but typically only weakly so, and why might that be? Well, social isolation refers to an observable and ostensibly objective state of people's social life, whereas loneliness is subjective. Thus, people can feel lonely or isolated even if they are not alone in an objective sense. Objective assessments of social isolation include things like social network size, frequency of social interactions, marital status, social engagement in the community with groups, with religious organizations, and volunteering. As a subjective state, loneliness arises when people perceive that their social relationships do not achieve their desired level of connectedness in number of relationships, but more typically in the quality of those relationships. In addition, loneliness is unpleasant by definition. Social isolation need not be unpleasant. This hinges in part on whether an individual has control over their social state. When solitude is chosen, like it is when I'm preparing this webinar, it doesn't evoke feelings of loneliness. When it is not chosen and a person feels there's little they can do to change their social circumstances, loneliness is more likely. Moreover, when loneliness sets in, there is a risk that people will begin feeling helpless, believing that there is nothing they can do to achieve the sense of social connectedness that they desire. Next slide. How prevalent is social isolation? In this study that used health and retirement study data, social isolation was defined as a composite measure of social network size, frequency of contact, and network diversity, meaning the range of types of relationships that people had with friends, relatives, neighborhoods, and so on. Next. Among Medicare beneficiaries, mean age of 74 years of age, social isolation scores are clustered, as you'll see, at the connected end of the scale, such that only 14% are in the isolated tail, 70% are connected, and 16% were what these authors called well-connected. Next slide. What about for loneliness? In the case of loneliness, it's measured in this study using the 3-item validated loneliness scale from the UCLA loneliness scale. This is data from the National Social Life Health and Aging Project in 57 to 85-year-olds. Each of these 3 items, asking how often people feel isolated, feel they lack companionship, feel left out, are answered on a scale where people can choose either never, occasionally, or often, and that creates a total score. So next slide, please. What this illustrates is the prevalence of loneliness when you take a particular cut point. You make a decision that you're going to call lonely those people, in this case, who respond to at least 2 items saying they at least occasionally feel this way. You get an estimate of about 30% reporting loneliness, 70% not lonely. And this falls pretty much within the range of what the literature shows, where 20 to 40% of the population of older adults tends to report loneliness. Next slide. We have looked also at this question of whether loneliness is an epidemic among older adults in particular, and not in the population at large. If we define an epidemic as a sudden increase in the proportion of people affected, then we should see that more recent cohorts should be suffering greater loneliness than older cohorts. For instance, 70-year-olds born in 1950 should be lonelier than 70-year-olds who were born in 1920. We did not find this to be the case. What you're looking at is a very robust finding, and that is an age-related change in loneliness, where you have both HRS and NCHAP data on each plot, one for men, one for women, left side for men, right side for women. And what you see is a decrease in loneliness from about age 50 to 75 or so, a decrease note, and then an increase after age 75 into oldest old age. All right, next slide. Why do we care? Sort of the be-all, end-all is, are we going to live as long as we might expect if we're lonely or isolated? And the long and short of that is probably not, at least from this meta-analysis conducted by Julianne Holt-Lunstad and her colleagues. The risk for early mortality was similar, whether one assessed it as loneliness or living alone or a composite measure of social isolation. All of these indices conferred equivalent risk for premature mortality. Next slide. I'm going to pass over this one in the interest of time, but it's there for your reference. So for other indices of health, not just mortality, but more proximal measures of health, you see that loneliness has been associated with a range of health outcomes that could play a role in early mortality. And we see here evidence of an increased risk of hypertension, myocardial infarction, stroke, diabetes, high cholesterol, cognitive decline, and dementia. And what these all have in common is systemic inflammation. And I would like to go to the next slide, where we see a role for inflammation borne out. This is a study of middle to older age adults that compares those who'd been chronically lonely at each of 3 consecutive years and those who had not been lonely for any of those 3 measurement occasions. And we see that the lonely and non-lonely groups differed in the genes that were downregulated versus upregulated. It's a systematic difference such that anti-inflammatory genes were underexpressed in the lonely group and the pro-inflammatory genes were overexpressed. In essence, this gene expression profile represents simultaneous increase in inflammatory processes that are allowed to proceed without the brakes of an anti-inflammatory process. So a runaway inflammation in lonely relative to non-lonely people. Next slide. There is some evidence that the association between loneliness and inflammation differs among subpopulations of older adults. In this slide, I draw your attention to the second panel, in which loneliness is associated with a greater increase in inflammation among Hispanics than whites over a 5-year follow-up. Next slide. I mentioned earlier that loneliness has been associated with an increased risk of dementia. In this new paper, it just came out a month or so ago, loneliness predicted a 40% increased risk of dementia. What's notable here is that this association held after adjusting for social isolation, further reinforcing the importance of distinguishing between loneliness and social isolation, related but distinct constructs. Next. In another study that included social isolation and loneliness as related but distinct constructs, Santini et al. Used the term social disconnectedness to refer to a composite of measures of social isolation that I mentioned earlier. Perceived isolation was assessed using the 3-item loneliness score in combination with some social support items. And what they found using 3 waves of NSHAP data, 2005, 2010, 2015, is that social disconnectedness or isolation predicted greater loneliness or perceived isolation at 5-year follow-up, which in turn predicted more depressive symptoms and anxiety symptoms at yet another 5-year interval. There was some evidence of the reverse direction as well, but this primary connection between social isolation, both objective and subjective, played out in this way to predict increased depression and anxiety. Next slide. I'll just mention quickly that there have been a range of health behaviors that have been associated with loneliness, sleep, physical activity, smoking, so on. I want to go to the next slide and to illustrate just a recent example, which was cross-sectional in nature, but it looked at sleep quality measured 2 ways, both as a self-report measure and using an actigraph, so a more objective measure of sleep quality, and related those 2 measures to both loneliness and social isolation. And in fact, found that sleep quality didn't matter how you measured it, self-report or objective, it was associated with greater loneliness, more social isolation. So it does reduce a concern that some people have that lonely people are providing biased self-reports. We do now see that even with an objective measure, that sleep quality is impaired in lonelier people. Next slide. I have not yet mentioned the impact of caregiving on loneliness, where spousal caregiving becomes increasingly prevalent with age. So in this study, couples in NSHAP who were not yet providing spousal care in 2010 were followed to 2015 and their well-being assessed as a function of whether they had become spousal caregivers in the interim. And this study was unique in that the physical and cognitive health of the spousal care recipient were each considered in the analyses of the impact of caregiving. I draw your attention to the last bullet. Husbands who became caregivers for their wives became more lonely and anxious at follow-up, the poorer their wives' cognitive ability at follow-up, even accounting for the change in their wives' cognitive function between 2010 and 15. Not true for wives, where could get into a gendered discussion here. Just to highlight that caregiving has an impact on loneliness that is partially dependent on cognitive function. Next slide, please. And probably the slide after that. Because I want to quickly review a couple of findings that I think are relevant because of the role of economic as well as social factors in today's environment. We found that a negative financial shock increased loneliness in older adults over a 2-year follow-up period. As a rule, across this long time period, 2006 to 16. But during the Great Recession, that impact was reduced. What does that say about current times? Perhaps because we're all in this together, like we were during the Great Recession, we won't see as great an impact as we might have otherwise. It's an interesting comparison with how this is experienced when it is experienced seemingly alone. The next slide shows how urban adults, in this case in Chicago, are affected by violence exposure, how that makes them feel more lonely. And I mention that because COVID also happened with racial unrest, and the violence that's surrounding it is ongoing, and that could in fact exacerbate the problems that we're having around loneliness. And finally, I wanted to briefly mention that older adults, though they are at increased risk for physical health problems, contracting the disease, dying from it, they are not necessarily at higher risk for the mental health problems or even loneliness. COVID response tracking study we've been conducting 3 waves, May, June, and July, August of this year. And we see for each of the 3 loneliness items that the prevalence of feeling this way often is much higher, it is higher systematically among those younger than 65 than those 65 and older. So there's something about the older adults that is perhaps endowing them with some kind of resilience to the effects of this era, COVID era. And I'll end there. Thank you.
Thank you so much, Louise. We're going to move right on to the presentations from Drs. Cotwall and Perry Sonoto. Take it away.
Thank you for the opportunity to speak with you in this wonderful forum, and Louise for starting this excellent discussion. Carla and I will continue by thinking about loneliness and social isolation among older adults during the COVID-19 pandemic. Next slide. We will be discussing 3 primary topics. First, we will briefly touch on definitions of loneliness and social isolation. Second, we will examine experiences of loneliness and social isolation during COVID-19, drawing on findings from our study of Bay Area older adults. And third, we'll apply some of these lessons from our study and others to think about how to support older adults during the pandemic. Next slide. First, definitions. Next slide. To briefly emphasize Louise's prior discussion, we generally think of loneliness and social isolation as related, but distinct social risk factors as shown in the Venn diagram. These concepts build on a broader area of social disconnectedness. So loneliness is a subjective feeling that your social relationships are lacking, or discrepancy between one's actual and desired level of social connection. A popular phrase is, you can feel lonely in a crowd. So people may have many relationships or even be married, but still feel lonely. A growing body of literature links persistent feelings of loneliness to poor health outcomes, including depression, disability, physical symptoms such as pain, and death. In contrast, social isolation is a more objective deficit in the number and frequency of interaction with family, friends, or the community. So how often are individuals actually seeing their children or going to religious groups? So while, as Louise mentioned, while social isolation may not be emotionally distressing for all, it is associated with medical risks, including increased healthcare costs, limited access to key caregiver, financial, medical, or even emotional support during the pandemic. And so the key point here is that loneliness and social isolation are conceptually distinct with different potential mechanisms of impact on health. And it is important to consider both experiences during the pandemic. Next slide. Which brings us to thinking through these experiences during the COVID-19 pandemic. Next slide. We draw on our recently published study in the Journal of the American Geriatric Society. We recruited older adults from 3 Bay Area sites to ensure a diverse sample: the UCSF geriatrics programs, including older adults receiving outpatient and home-based care, Povia Senior Services, a nonprofit community program, and the nonprofit Curry Senior Center within San Francisco's Tenderloin neighborhood, a socioeconomically and ethnically diverse area of the city. We assessed individuals' psychological well-being, how they were socializing, unmet medical needs, and open-ended responses at baseline and 2 to 4 week follow-ups. Next slide. We recruited 151 respondents for our study and conducted 460 interviews between April and June. Our sample was on average older, racially and ethnically diverse. On the right-hand side, you can see some of the different characteristics of our sample, including about 2/3 were female, 2/3 living alone. A substantial proportion had hearing or vision impairment, or functional disabilities. Next slide. Overall, about 1/3 of our sample described frequent feelings of loneliness based on the UCLA loneliness scale, which was discussed by Louise. And over half of older adults attributed worsened loneliness due to COVID-19 restrictions at least once during the study period. These feelings clustered with other feelings of psychological distress, as shown on the right-hand side, including worsened depression, worsened anxiety, worries about COVID-19, and worries about their medical care. Next slide. We found that, on average, rates of participants reporting worsened loneliness decreased significantly over time, suggesting a level of resilience among many older adults. That's consistent with several recent studies on psychological distress, including the data just presented by Louise, as well as studies conducted by Martina Lucetti and colleagues and Megan Ham and colleagues cited below. Individuals who improved over time reported positive emotional coping or enthusiastic stories about adopting new technologies. Next slide. However, there was a notable subgroup of participants, about 40% in our study, where loneliness worsened or persisted. And this group followed 3 general patterns. Next slide. The first was there were individuals where loneliness levels increased over time since shelter-in-place orders. On the right is a graph showing UCLA loneliness scores on the y-axis, with higher scores indicating more frequent feelings of loneliness, and on the x-axis, time since shelter-in-place orders in days. Each line represents an individual participant's trajectory. In general, you can see scores rising over time for this subgroup. Next slide. Here is one participant highlighted in the red on the graph with a representative quote. Before the virus, I was socializing and seeing people a lot, but I feel a lot more lonely and isolated. And on follow-up, I love technology, but I've had trouble keeping up. Technology is something I feel comfortable with, but totally out of date. This highlighted a consistent theme from open-ended feedback, discomfort with new technologies. Next slide. The second pattern was loneliness levels, which were consistently high over time, shown on the right. Next slide. Here is one participant, highlighted again in red, who was consistently at the highest levels of loneliness on the scale. She mentioned, "This has been the hardest thing I've had to do in my entire life. The isolation has made my mental and physical health worse." This was representative of a second theme from open-ended feedback, difficulty with emotional coping. Next slide. The third pattern was loneliness that was relatively mild over time, shown on the right, with scores less than 3 on the UCLA loneliness scale. Next slide. For example, participant 81, who had low scores, around 1 to 2 points, mentioned, "I'm in my assisted living facility. I've been a little isolated and we're confined, so we're safe, but life's pretty dull." So these individuals are coping reasonably well, but may be at risk over time. Next slide. And how about objective social connections? We measured the frequency of socializing by different modes of communication. On the figure on the right, you can see different types of communication on the x-axis, and on the y-axis, the frequency of weekly use. Telephone communication was the most common. However, our participants had markedly low levels of video and internet interaction, as shown in the red box. 76% had minimal video interaction and 43% minimal internet use to socialize, and these levels persisted throughout the study period. Individuals who were more objectively isolated and did not use technologies reported unmet health needs more frequently, including difficulty finding help with bathing, shopping, obtaining medications, and food insecurity. Next slide. I'll now turn it over to Dr. Perissinotto on how we can apply these lessons to support older adults. Next slide.
I want to help us turn to, with these findings that have been presented by Ashwin and also by the excellent presentation by Louise Hockley, is how do we think about some of this data that we're generating and think about real life, real world experiences, either in our clinical settings or in our community settings. And if you're not already aware of this, I hope that the people tuning in can look to the National Academy of Sciences, Engineering, and Medicine's report on social isolation and loneliness in older adults, opportunities for the healthcare system, because there's some really excellent recommendations that come out of the report about applying the evidence. And what we see here on the right is thinking about what are the key conclusions from this report. And the first is developing a more robust evidence base, which is in part why Ashwin and I embarked on this study during COVID. The second part is then how do we take these incredible research findings and translate this into healthcare? What that means is understanding the healthcare risk and really learning how to identify loneliness and isolation in healthcare settings. The third one is improving awareness, and this is actually what we're trying to do during this webinar today, as well as strengthening ongoing education and training, which we're hoping this is a start of this during this webinar, and that those of you listening will then similarly translate this forward into your work settings. And then the last very critical part is strengthening ties between the healthcare system and community-based networks and resources. So that is a brief overview of the report that I hope you will look at. Next slide. So when we think about what we do on the healthcare side, we've already seen some information from the prior two presentations about risk and who we need to worry about. And what I want to think about this is when you're looking at an individual's risk, thinking about it from a population level framework and dividing things into primary and secondary prevention. So in primary prevention, which is also the bottom of the pyramid on the right, is thinking about identifying patients who may be, or people who may be at risk for loneliness and isolation. And from what we know from the data, that may be women, people of lower socioeconomic status, the oldest population, LGBTQ adults, and then also think about people with recent losses. When we think about secondary prevention, and this ties to the middle part of the pyramid and the top, it's those people who are already lonely or isolated and are starting to see the consequences of this, and how can we start to decrease this? This means that we need to ask about screening or ask about loneliness and isolation and know which interventions work. Next slide. So as we saw from the data we presented from our study during COVID, many older adults are experiencing worsened loneliness, but it is not universal. So what this means actually, and what we can take and combine it with the National Academy of Sciences recommendation, is that we only know this because we have to do an assessment. So in our study, we did an assessment by phone, which means that these tools actually can be used by phone or in person or electronically, depending on your venue. And without asking this, we don't know what people are experiencing. We did use the UCLA 3-item loneliness questionnaire for loneliness. And for social isolation, there's different tools that you can use. This is also highlighted in the National Academy's report. And an emerging term, and something that was referenced also early on, is this term social disconnection. And there's a new tool developed by Matthew Smith in conjunction with AARP that's really looking at an upstream risk assessment. So just wanted to give you some tools here. And again, you can delve more into this into the National Academy's report. Next slide. One of the other key findings that we've seen, both in the study that Ashwin and I just presented from our work, but also from the National Academy of Sciences, is that there is a marked digital divide amongst people in our country, mostly divided by age, but also socioeconomically. And what this means is that we have to be careful not to overly rely on technology-based solutions to address loneliness and isolation. This does not mean that we do not use them, but it means we have to think about who these technologies can serve, who may be left out, and how do we address this gap. And the other part is that, certainly because of the pandemic, there's a tendency to move completely towards digital, but it's really thinking through what exceptions can we have to allow safe in-person interaction, and how do we do that in a safe way, which is something that, as we know, as the data keeps changing with this pandemic, we're frequently having to do. Part of this will be, in order to figure out who should be seen in person versus digitally, it's thinking about those at highest risk who may not have other access otherwise and may need something in person. Next slide. once we've identified people who are screening, quote unquote, positive for loneliness or isolation, it's important as we think about interventions and what to do is how to make sure that our interventions are targeting what is going on. What that means is you can't have a one-size-fits-all approach. We have to think about social support, enhancing interactions, and how people are adapting to this. And those are direct interventions. Indirect things are also thinking about vision and hearing losses, which we saw in our sample is important, dental care, and urinary incontinence, which can affect things. And then lastly, thinking about how can we socially prescribe to local community-based programs. Next slide. And the final slide here is that as we start to ask adults about loneliness and isolation, it is likely that you will find unmet needs. And these unmet needs are uncovered, and so you have to be prepared to know how to deal with these. So with technology, it may be facilitating use or recommending technology that may be more usable. Food insecurity has been a topic that has come up. And certainly what's been surprising is that there have been more people with medication and other functional needs that have been uncovered during the pandemic that we otherwise would not know about had we not asked about loneliness and isolation. And again, this points us to the need to partner between clinicians and researchers to make sure that we have the right tools in clinical settings. So, and I believe that was my last slide, but next slide just in case. Okay, so lots to talk about here, and I will pass it on to the next presenter, but we want to go ahead and thank our funders here on this slide. Thank you.
Thank you both. Let's move on quickly to Sharia Robinson-Lane.
Afternoon, and thank you all for joining us today. Next slide, please. There's no relevant disclosures that I have. Next slide. And moving along the same thing as our first two presenters, we're going to spend the next several minutes thinking about how social isolation really complicates aging in place. And as we've already learned, these are two separate concepts that we're talking about here, social isolation and loneliness, but both of them have effects on health and the outcomes for many of our older adults and their family caregivers that are providing care for them. And so what I aim to do is to provide a little bit of a focus on health disparities and how that affects care, particularly pain and function. We'll talk about some of the particular challenges that family caregivers face. How these disparities then link to the COVID-19 risks that we're seeing in the outcomes, and then end with some information on available supports. Next slide, please. So as we've discussed a little bit, particularly in that first presentation, social isolation does have an effect on health. We know that it's linked to decreased gait speed, poor cognition outcomes, depression, overall worsening of health, daytime functioning for adults, particularly older adults that have already been experiencing some cognitive declines. Individuals have much worse sleep quality, which of course then contributes again to cognition and daily functioning. And then of course there's increased mortality overall. And so it's really important to address these things. We also know that there's increased nursing home admissions related to individuals who experience more social isolation. And when we talk about the poor health, it has a particular effect on heart disease, hypertension, and stroke. Next slide, please. When we look more at social isolation and the effects of social isolation, it should say on loneliness, there's a good article by Finley and colleagues that talks about the specific ways in which social isolation affects loneliness. And there they discuss the physical and mental health outcomes. So when we talk about poor health, that includes depression. And it really made it challenging for older adults that participated in this study to engage with those that reported increase in social engagement. I mean, this was a lot. They had contacts with medical team and healthcare activities. So the ones who found that it wasn't as bothersome to them they were still having contacts with these individuals I mentioned in their medical teams and their health care teams. And so it lessened the effects of the isolation, whereas we didn't always see this with some of the other groups. Some people actually had a personal preference for being isolated. And so social isolation didn't necessarily lead to loneliness, because just like some of you like to keep to yourselves and you're sort of doing okay with this space that we're finding ourselves in the midst of this pandemic, many older adults are exactly the same way, that they've always sort of kept to themselves. They keep small groups, and so that's just their personal preference. And so the loneliness isn't a particular problem. And so we have to be also thoughtful about not necessarily clumping everyone into the same groups and assuming that everybody wants increased contact. But what really does make a difference, as we talked about how that concept of feeling loneliness is more so a subjective experience, is that sense of loneliness that a person may have. And so that could come from living alone and not having social contacts. And many older adults report that it's a lot more difficult to make friends the older that you get. And the challenge is that, as we have seen during the pandemic, where we've had to shut down many of our community programming, such as our senior centers and community centers, where older adults may have had the opportunity to gather and develop friendships, that's no longer the case. And so people aren't necessarily going to develop new friendships during this time, or it can be a lot more challenging, and we have to be a lot more creative in finding ways to make that take place. The last thing here is with this idea about safe spaces. One of the reasons that it contributed to people being socially isolated is that their sense of safety really impacted their community engagement and then led to the isolation. And that's exactly what we're seeing right now, right? Out of safety, many individuals are staying home in order to not get sick with coronavirus. And those that have more medical needs, so they still have healthcare providers and medical teams either calling them or perhaps even in and out of their homes, don't necessarily feel the same effects as individuals who have who may be healthier than these folks. Next slide, please. So based on the literature, and this is a mini review that was done by the authors listed here, when we looked at those who were most at risk for loneliness and social isolation, they listed single women, those that had little contact with friends, people with worsening physical health, those with the lower levels of education and income. And those last two there also point to the concerns that we've seen with use of technology, right? It's going to be more challenging, and you're going to have less access to technology if you don't have an iPad at home, or perhaps you don't have broadband or internet access, or you aren't very familiar with how to use some of the technology that many of us have had to quickly adapt and begin to use. The HRS estimates that 19% of non-institutionalized adults over 65 reported feeling lonely over the prior week. AARP found that about 25% of folks over 75 were lonely at least some of the time, based on the survey that they did. And the other risk factor here, when we talk about single women, are women who are never married, divorced, and widowed, which is also interesting because that same group, people who are never married, divorced, widowed women, also tend to have the longest longevity. And so even though these individuals are most at risk for loneliness, generally their health outcomes tend to be much better. Next slide, please. When we look specifically at health disparities, this is the NIH framework, and particularly from NIMHD, the National Institute on Minority Health and Health Disparities. These are some of the areas to pay attention to as we consider health disparities framework in health outcomes, you want to make sure that you're looking at things from both an individual and interpersonal as well as a community level. And so at the individual level, really consider what are some of the behaviors and coping strategies that individuals are using, what are their care preferences, and think about asking those questions. Interpersonally, how are we encouraging family functioning and facilitating families to function optimally? How are we increasing social networks for folks? And then at the community level, what is the physical environment like? Is it safe? Is it accessible? And what are the available services and resources available to the people in our communities? Next slide, please. Pain particularly affects function. It is correlated with depression and many poor health outcomes. We know that it's very costly, and particularly for persons of color and older adults, there's a long history of inadequate pain control. Next slide, please. We know that about 70 to 90% of persons with advanced disease experience pain, and when pain is rated at 5 or higher, and some research indicates a 4 on a 0 to 10 pain scale, that it impacts quality of life for individuals. And we know that most older adults, about 93%, have at least one chronic disease, and around 70% have at least 2 chronic diseases. So many of our older adults are experiencing pain, and then the secondary effects of that, which can increase disability and loneliness. Next slide, please. In cognitive health, there's also great disparities both in the incidence of Alzheimer's disease. We're finding that persons of color are receiving later diagnoses. They have more comorbidities, including mixed forms of dementia and, of course, mixed or increased mortality. And that there's also an increase in use of family caregivers to help people to age in place at home. Next slide, please. As our previous presenters spoke about a bit, it's really important that we think about how to support our family caregivers, and part of that has to do with identifying who they are. Family caregiving is associated with negative health effects such as hypertension, obesity, diabetes, depression, and worsening overall health. Next slide, please. And particularly for persons of color, there's increased risk factors that are related to COVID infection, which are listed here: your chronic kidney disease, obesity, diabetes, hypertension, and dementia, which we're seeing with these increasing rates of both COVID infection as well as COVID deaths amongst persons of color. Next slide, please. So one of the things that's really important that we do is, or pay attention to, is that the support services can vary significantly between communities. Oftentimes the lower income communities have the least services available, as well as our rural communities. Families a lot of times aren't really aware of what services are available to them. And so one of our really great resources to get in touch with is the local area agencies on aging. They often facilitate services for older adults within communities and can help people to determine what's available to them in their communities, both in person as well as virtually. As our other presenters mentioned, it's really important to think about using low tech to stay connected. So going back to the things that we used to do in the past, calling people on the phone, writing letters, putting cards in the mail, and doing these socially distanced in-person visits with folks. It's okay to knock on the door and drop some things off, or have a porch visit or a visit in the yard to touch base and keep people connected. There's also some really promising studies in engaging technology, but technology that can be used using voice commands like Google Home and Alexa, that we're finding people are pre-programming, like with phone numbers and different sorts of things. And then older adults are really enjoying being able to use these more advanced sorts of technologies that are really simple to learn. Next slide. So overall, the things to remember here are that social isolation and loneliness can really worsen health outcomes. Some folks are more at risk for health outcomes than others. And so it's really important to find ways to help people to stay connected, both by maintaining and managing their health and facilitating social relationships. pay particular attention to the pain needs of individuals and changes in cognition so that we can identify those and intervene soon. And then also we want to identify and then check in on your family caregivers. Thank you.
Thank you, Sharia. I think that was a great segue to Donald Smith's presentation, since he's from the Area Agency on Aging.
Perfect segue. We'll be talking about serving people living alone with dementia. Next slide. I'll talk a little bit about the Older Americans Act, which is all the AAAs and their subcontractors. The work we've been doing in the area of social isolation, loneliness, and dementia for 14 years now in Tarrant County, and what seems to be working and not working. Next slide. As Sharia mentioned, the 600 area agencies on aging are great partners, as well as their 20,000 service providers. The Older Americans Act was passed in 1965, same year as Medicare and Medicaid, as part of LBJ's Great Society, amended in 1973 to create area agencies on aging. We're kind of unique in Tarrant County in that we're one of only 2 area agencies on aging in the United States that are part of a United Way. Next slide. We're the 3rd largest urban county in Texas, but we have a higher incidence of Medicare beneficiaries diagnosed with Alzheimer's. We're about 2 percentage points above the national average. And I will not be talking about the Dallas Cowboys who play in Tarrant County today. Next slide. We also have the highest mortality rates for Alzheimer's disease among all the urban counties in Texas, including the people in San Antonio, Dallas, Houston area, Austin area. Next slide. We've been working in the area of social isolation since 2006. In fact, we had to rely on Canadian researchers for the distinction between loneliness and social isolation. And we're using the OR Social Resources Scale and the UCLA Loneliness Scale back in 2006 to measure outcomes. We've been working in the area of dementia since 2009. Our academic partners for this entire journey have been the folks at Baylor Scott and White Center for Applied Health Research in Temple. That's Alan Stevens and Jinmi Young Cho. I guess the biggest takeaway from the past 14 years is, particularly when it comes to the population with dementia, we can make the biggest difference if we focus on people that have low to moderate cognitive impairment. Next slide. And many of the other presenters have already mentioned the fiscal impact. This is an interesting chart because it shows that for individuals with Alzheimer's or dementia, it costs Medicaid 23 times as much as someone without Alzheimer's or dementia. Next slide. The cost is even greater for the population of people living alone with dementia. And one of the reasons for that, according to the Alzheimer's Association, 50% do not have an identifiable caregiver. So that population of what we refer to now as elder orphans is definitely increasing. Next slide. We were very fortunate in 2016 to have received funding from the Administration for Community Living. We decided to focus on health disparities, underserved and unserved populations, particularly people of color with a higher incidence of dementia. Next slide. So we've, during that 3-year period, we served over 600 caregivers and people with dementia. I guess the most exciting thing that we were able to accomplish is providing culturally and linguistically appropriate services training to all our providers. As you can see, we were able to substantially increase the amount of services delivered to African American, Hispanic caregivers and people with Alzheimer's disease and related disorders. And also all our partner agencies were trained on and began to use the 88 screening tool. Next slide. You can see from this slide, this is an excerpt from an article that appeared on the front page of the Fort Worth Star-Telegram above the fold. You can see at this point in 2017, I was becoming increasingly concerned about the growing population of people living alone with dementia. Next slide. This resulted in a series based on the previous article. There were several articles written about this particular population. In this particular case, we were able to prevent this client from burning down their house, which we're not always able to do. Next slide, please. So this led to an expansion grant from the Administration for Community Living to focus specifically on the population of people living alone with dementia. Next slide. So over the past year, we've been able to screen over 3,500 people for dementia using the validated screening tool, the 88, and serve almost 400 caregivers and people with dementia. And we've kind of fallen in love with a new screening tool called the AZQOL. We don't have our final evaluation report, but we know that we have 135 people that have completed that pre and post. So we're anxious to see if there's been any improvement in quality of life for the people that we're serving. Next slide. So to supplement the great quantitative research that was done by Baylor, Scott, and White, we conducted a focus group of direct service workers. And I posed the question, what is the experience of people living alone with dementia? And the one big takeaway for me from this focus group is that it's much, much easier to screen people or even diagnose them than it is to get into the home and begin providing multiple services. Next slide. We got together with our ACL grantee partner in Houston, Baker Ripley, and put together a list of what we think are the most needed services for people living alone with dementia. And we're now providing almost all of these services in Tarrant County. Next slide. The healthcare system, for the most part, has not done a very good job of adapting to meet the needs of this population. I think it's unrealistic to expect a lot of these people, particularly those without caregivers, to be able to access transportation and to make their way into a doctor's office for diagnosis. And as you know, lack of diagnosis is often a barrier to care. I also do not think that telemedicine is particularly a panacea for this population, as has been alluded to by some of the other speakers. Next slide. One of our primary partners in all this has been Meals on Wheels of Tarrant County. I think they're probably one of the best Meals on Wheels operations in the United States. You can see that about a little over a third of their clients are estimated to have dementia based on 2 validated screening tools that we use. And just last month, we had 19% or over 1,000 people living alone with dementia. Next slide. One of the great things about working with Meals on Wheels, or even area agencies and aging for that matter, is we're already using functional assessment screens to determine eligibility for our programs. Next slide, please. So these are actually 3 questions from an ACL state mandated home delivered meal assessment. We use those questions to trigger the administration of the ADA. And again, you're going to find something like this being used by all the area agencies on aging and their subrecipients. Next slide. So we're working on quite a few related initiatives in Tarrant County. Probably the biggest one right now is Dementia Friendly North Central Texas, which would allow us to replicate many of the things we're doing in Tarrant County throughout the 16-county Dallas-Fort Worth area, which constitutes 25% of the population of Texas. We're also excited about a grant we received from the largest hospital system in the Dallas-Fort Worth area to address social determinants in isolation and high-need zip codes. Next slide. Finally, I would like to acknowledge all the folks over at the Administration for Community Living, particularly Aaron Long. Thank you so much for your support. And thank you.
Thank you, Don. That was a tremendous amount of work. Appreciate you going over all of those resources. We'll now end the panel with a talk by Hiroko Dodge.
Hello, hi. My name is Hiroko Dodge. I'm professor of neurology, and I'd like to introduce our project called iConnect today. Now, my internet, unfortunately, is very slow today, so I'll just stop the video so that people can hear better my voice. Next slide, please. I don't have anything to disclose. Next, please. Okay, as Dr. Hockley and others already presented, it is well established that social isolation is related with negative health outcomes, including dementia. For example, the most recent report by the Lancet Commissions, which was published a couple of months ago, showed that 4% of dementia cases can be prevented by eliminating social isolation. This population attributable percentage of 4% is the same magnitude as smoking, depression, and even higher than other risk factors of dementia, such as lack of physical activity, pollution, and diabetes. Next, please. However, there are several unanswered questions by observational studies, which are published these population attributable risk. For example, does increasing social interactions lead to improved cognitive function? What are the biological mechanisms and who gains? And how much of the efficacy is mediated by psychological well-being? To answer to these questions, clinical trials are needed. We have been conducting, next slide, please. Thank you. We have been conducting a series of randomized controlled trials over the past 10 years, which aim to enhance cognitive functions through increasing social interactions using video chats. We are fully aware that there is a difference between social isolation and loneliness. As an intervention study, here we are aiming to examine whether conversational interactions, which is a core component of social interactions, can modify brain functions and improve cognitive functions. In this series of behavioral intervention trials, participants in the experimental group engage in about 30 minutes of conversation with standardized and trained interviewers, while the control group receives weekly 10 minutes phone check-in. The conversation is semi-structured because we would like to create an environment where participants can organize, develop, and convey their own thoughts in a natural setting, while the topics and certain prompts are standardized. Each week, they can meet with or rotate among different conversational staff for 6 months. The advantage of using video chats include, it's obvious, but it requires little motivation, and therefore it's feasible even among people with apathy, and we can reach subject participants with chronic conditions and homebound. We are providing equipment and free internet services to these participants. Next slide, please. So briefly, I'd like to share what we found so far. In the pilot study, which was completed in 2014, we found promising results despite the short duration of the intervention, which was 6 weeks. Adherence was very high, almost 90%, and the experimental group gained in language-based executive functions in comparison to the control group. Cohen's D was 0.5, which is a reasonably strong effect size. And we also targeted age 80 and older in this trial because oldest old group is the highest risk of facing the highest risk of dementia, and also they are also high likelihood of being socially isolated. The result was published in Alzheimer's Dementia, Translational Research and Clinical Interventions in 2015. Next slide, please. Okay, so now I move to the main theme of my talk today. Using the remaining time, I'd like to highlight technological aspects of our interventions and how we are conducting the trial under COVID-19 pandemic. Since we are targeting those who are socially isolated and most of them live alone without anyone who can assist them, it is important to use user-friendly devices in order to increase retention and to reduce confounding effects derived from cognitive stimulations, such as running internet and chat systems in these trials. Next slide, please. Okay, as an example, in our pilot project that I just mentioned, we provided video chats with automated pop-up daily stimuli pictures as shown here. This pilot study was conducted almost 10 years ago, and therefore we used very heavy, bulky monitors. Next slide, please. Now, more cost-effective, compact devices with high picture resolutions are available. In the ongoing project, we are using Chromebooks. As with the previous pilot project, the conversation can start with one touch. When the participants touch the green chat circle, conversation staff greets with the participants. Next slide, please. We also have a restart button, highly visible, which is important when malfunctions occur and the restarting is needed. Next slide, please. Here's a picture when the video chat is in session. Next, please. And here's a screenshot on the staff's end. We instruct the conversational staff to have eye-to-eye contact. The gentleman with the yellow shirts here is a conversational staff. Okay, next slide, please. We provide earphones to all participants, although not all not all participants need to use the earphone. Next slide, please. Due to time constraints, we did not go over details of our conversational materials today. But briefly, we have a daily theme to discuss. As an example, here the daily theme is World Wonders. Next slide, please. So under each theme, participants can choose which pictures they want to see and then discuss first out of the 3 pictures. Next, please. This is, if participant chose like pyramid, then the pyramid picture shows up. And then participants can describe what they see in this picture. as detailed as possible. Next slide, please. After the participants describe the picture, the staff will remove the slideshow from the participants' view so that the two can chat face-to-face. On the staff end, the notes section of the PowerPoint is prepped with conversational tools, including factoids and potential questions to target each cognitive domain. For example, it might ask something like, how do you think the builders of the pyramids influenced modern technology or construction? Then this kind of questions can stimulate critical thinking skills among participants. After a few questions, staff are encouraged to let the conversation flow naturally. Next slide, please. And during the first chat of each week, we also use the PANAS to assess emotional effects of participants before and after the chat. This is mainly for standardization of conversational staff's skills. So far, we have over 150 prepared themes, including historical events, philosophical ideas, social issues, activities, and travel. Next slide, please. Now going back to the Chromebooks that the participants use. One of the most challenging factors is to provide remote support. We need to address malfunctions remotely with clear directions, which can be understood by even the oldest old who often have vision and hearing impairment. In our study, all plugs and codes are color-coded in order to avoid technical terms such as power plug or audio jack. Next slide, please. When the power is unplugged or internet connection is lost, warning screen shows up automatically. This happens even during the chat without interruption. Now, the audience might be wondering why we have to create this type of device when quite a few user-friendly video chat devices are already available these days. However, these commercially available platforms cannot be brought into HIPAA compliance and thus are not used in healthcare or healthcare research like ours. Especially, we are recording audio and video and examining, for example, changes in speech utterances as one of our outcomes. Security of stored data is one of the top priorities for our research team. Next slide, please. So finally, how we are handling the pandemic. We are fortunate that we could keep providing our interventions during the pandemic when all the in-person contacts were suspended. We felt it very important that we kept providing social interactions, especially during the pandemic. We are now successfully delivering Chromebooks to our newly enrolled participants and install them remotely. Now, one large drawback is that before COVID, we were providing free internet service to those who do not have internet access. Under COVID, installing new internet and then connecting it to the new device without entering their homes was not possible. So unfortunately, we have to limit the new enrollees after COVID to those who have already internet connections. This change in inclusion criteria might affect the generalizability of our results. We also changed the assessment modality from face-to-face in-person assessment to telephone cognitive assessment. Now, we were using the NIH Toolbox Cognitive Battery as one of our exploratory outcomes. So we piloted delivering NIH Toolbox iPad to the participant's house and remotely assessing cognitive functions with phone instructions. However, it turns out that it was too difficult for participants to take the test with phone instruction only. Also, we were not convinced that the test can be standardized through phone instructions. So unfortunately, we had to drop NIH Toolbox assessments. Next slide, please. So I hope our intervention study can provide useful information for protocol developments in other behavioral interventions which use video chat interactions. To our knowledge, we are the first clinical trial which try to enroll socially isolated seniors aged 80 and older. This is a group who are often excluded from any pharmacological and non-pharmacological studies. It is challenging to recruit socially isolated subjects because they are less likely to be aware of the clinical trials and are less likely to volunteer to the trials too. So far, 2999, almost 30,000 subjects were contacted, and 1,200 subjects were screened by phone, and only 388 met our inclusion criteria of social isolation. So that means 1.3% of total contacted participants can be enrolled into our study. Next slide, please. We can skip this one. Okay, so here are my three concluding remarks. One is, can social interaction improve cognitive functions? Based on our pilot study, yes. We hope we can provide more evidence and the underlying mechanisms from the ongoing study. Second, reducing social isolation in a large scale is far more promising now than ever with technological advancement. But we need to make sure that the devices are user-friendly and safe and secured, and assure internet access to everyone, including rural areas, to reduce further digital device and health disparities. And finally, we also hope that materials developed in this iConnect trial will become a practical therapy against social isolations. Because currently we do not have much therapies on hand. Okay, next slide, please. This is the last one. So I'd like to thank my iConnect team. This is a truly multidisciplinary team involving engineers, neurologists, MRI specialists, gerontologists, and social workers. We also thank NIH for continuously supporting this project. Thank you.
Thank you so much. We're going to transition quickly now to the question and answer period, but I just wanted to let you know that there's more to come. So if you enjoyed this webinar, we have 2 more coming up in the winter and spring. And if you need to find out more information about any of the webinars, or if you'd like to recommend that any of your friends or colleagues watch this webinar, you can find all of that information on the website that's on this slide right now. So if we move to the Q&A period, I guess the first question I'd like to ask the panel is, what questions do they think others should specifically ask individuals to find out whether they're lonely or socially isolated? And that might include healthcare practitioners, case managers, social workers, casual friends. What do you think are the best questions to ask to just get a sense of where people are in this space?
In our clinical trials, we have to contact so many people. Therefore, we use Rubin's social network scale, which is only 6 items and can be done by phone.
And so does that scale mostly ask how many people you're in contact with on a daily or weekly basis?
Yes, it's 6 scales, and then so it's not emotional loneliness. It's more like structure. Is there any interactions?
And I think several times the UCLA loneliness scale was mentioned, and I think there's just a few items on that. So if someone wanted to do that unscientifically, to get a sense of someone in their neighborhood that they might be worried about, what are the items that are on the scale?
Can I also answer this one?
Sure.
That's another ones that we are using. We divided loneliness versus social isolation, and we recruit both people and then see this our intervention works with which group. So for, as I mentioned, social isolation, we use Rubens, and for social loneliness or lack of support, we use UC's loneliness scale, the 3-item version, which asks how often do you feel that you lack companionship, And how often do you feel left out? And the final third one is how often do you feel isolated from others? And some people are often it's kind of be so good as a isolated and lonely. So
Thank
this is a 3-item UCLL loneliness scale.
Thank you. Doctors Cotwall and Parasinoto, I was wondering if you could speak to whether clinicians are using these types of scales in their clinical work, actually in the office or hospital.
To that, I will just mention that at UCSF, we have been in the process of integrating both a loneliness scale and a social isolation scale into our electronic health record in an effort to screen. I would also just add that many of the existing scales are not specific to the challenges faced during the COVID-19 pandemic. So I would consider adding certain assessments of older adults' technology use to see if they're coping with restrictions. And that includes, access to the internet or other technologies, people's comfort level, and people's actual use of those devices.
Thank you. I wanted that this connects to, we've had a lot of interesting talks that have covered a range of different kinds of services and resources and studies on different levels of technology. And several of the questions that came in were about learning more about the impacts of these types of services, those that are available now, not just those that are in research studies, which will inform our care in the future. And there were sort of a series of questions about, are there programs where older adults can sign up now to get weekly check-in phone calls? Or do we know anything about services that don't require internet or smartphone access? Or alternatively, any programs to get older adults to use or learn how to use technology? So that's a fairly broad set of questions, but maybe someone will take a stab.
I can answer a part of that. Donald Smith will be able to answer this more, I would suspect. The National Area Agencies on Aging put out a report of how all the states are handling the challenges of COVID. And friendly visits, the telephone calls is top of the list. It's the most safe, accessible means people have of maintaining contact, for the agencies to maintain contact with the parties in need. Regarding the technologies, there are some spotty places that I'm aware of here in Illinois. There's an attempt to use virtual social interaction contexts where you have people learning how to work with a device that is actually brought into home under safe circumstances, PPE and all. And it's basically a large screen that's very easily interacted with directly. It's like Alexa on steroids or something. I don't know. Think about it, but it's proving to be well received as interacting with a face, the words.
Thank you. Don, did you want to comment?
Sure. Thanks, Louise, for partially stealing my thunder. I would recommend that everyone go to the website of the National Association of Area Agencies on Aging. It's n4a.org, and scroll down to recent publications and you'll find the one Louise was talking about, as well as one that was just released, engaging practices for helping older adults stay socially engaged. So,
thank you. Can you give the website again?
Yeah, it's n4a.org.
Thank you.
Or it's number 4.
And there's also a kind of a snapshot of what all the area agencies on aging have been doing nationwide since the onset of COVID-19. I think that's the report Louise was referring to. There's a lot of really good information the recent publications section on the N4A website.
Thanks so much. As long as we've got you on the line, someone asked a specific question about whether the Meals on Wheels study that you're doing in Tarrant County, whether it includes outcome measures of the effects on overall health for those that receive Meals on Wheels versus those that do not, or are you mostly looking at isolation and cognition?
We're mostly looking at isolation and cognition, but as I said, I'm very excited about the use of the AZQOL, which was recommended by ACL. So we should have some data on whether or not there's been improvement in quality of life as soon as we get our final evaluation report in, which we'd be glad to share.
Thank you. Sharon, I was wondering whether you could give a little more information on what you think some of the best ways are to address questions related to social isolation and loneliness in underserved and vulnerable populations.
Best ways to address it is connecting with the local community organizations that are already working with a lot of these populations. So that may mean more resource places like universities and assisted living facilities, long-term care facilities that may have activities going on, connecting with churches, local senior centers, and places that older adults may already be connected with to expand some of the programming. And we're starting to see some of this now. For example, a local senior center had, an assisted living facility had a virtual bingo and invited some senior centers in the area to participate. And we had a lot of older adults that weren't affiliated with that assisted living facility at all that chose to engage, and also sharing of questions, thinking about questions to ask for phone trees and starting phone trees with organizations to check in, to ask people how they are doing, if they have what they need, if they are staying connected in the ways that they want to. All of these are really helpful things that different organizations can do regardless of, what resources they have access to.
Thanks so much. I was also wondering, so there was a question here about gender differences. I think it was targeted at Louise because you had mentioned that there was an inverse relationship between gender and worsening cognitive health of their spouses. So it went one way for male caregivers and another way for female caregivers. And the question was whether you could suggest reasons for this difference. And I guess I'm broadening it if anyone wants to comment in general about gender differences in social isolation and loneliness.
Right. Well, in broad terms, the gender difference in loneliness in the older adult population kind of mixed, but usually females are lonelier. This particular study I was talking about is what happens to the spouse who becomes a caregiver whose cognitive function is declining. And husbands whose wives' cognition is worsening will experience an increase in, the data suggests. That wasn't true for women. It wasn't the opposite, they just didn't have that effect. Rather, among women whose husband's cognition was declining, they gained additional support from their friends. And I mentioned that as a gender difference because typically women orchestrate the social lives of the couple, the dyad. And so women are getting that extra support. Men not having their wife cognitively capable, perhaps, of maintaining a social life and themselves farming it, doing it themselves, are finding themselves deprived of that connection that they might need.
Yeah, and I'll just note here that suicide rates in older men, especially those without a spouse, I think are particularly high. So it's a particular concern in the community. Did anyone else want to comment on any marked gender differences that they found in their studies with regard to social isolation and loneliness and or responses to COVID? If not, I'll move on to the next caregiver question, which is about elder abuse. And we've heard that during the time of COVID, there has been probably an uptick in intimate partner violence as people are stuck at home with each other. And I'm wondering if any attention has been paid to this in terms of elder abuse in the context of social isolation, where it's actually a dyad or a caregiver and an older adult who are isolated.
Coming.
What can you expand?
Well, we've just launched a COVID study of the National Social Life, Health, and Aging Project. So we have some questions in there. We have the status of whether people were caregivers in the prior wave. So, and we know about elder abuse in prior waves. More often than not, it was financial abuse than it was anything else, but we measure other aspects. So to the extent we can triangulate using this COVID-specific data collection to learn whether that's been increasing at any level remains to be seen.
Thank you. I think we're nearing the end of the period, so I'm just going to ask one more question, which I thought was interesting, which was whether there's any evidence about whether having a pet helps mitigate social isolation and loneliness in older adults.
And that's one where I do have a bit of data, and it isn't our data, but it's always been a hard topic to get a handle on because, of course, it's a selection issue. Who gets a pet? And maybe it's who are prone to be really connected anyway who get a pet. But in fact, the most convincing study I saw was that people who get a dog become less lonely. And what made it convincing is what happened as a result of getting a dog. They ended up walking the dog and socializing with other people. And it was the amount of socializing with other people that actually accounted for the reduction in loneliness.
Thank you.
Just a little anecdotal information. Our Meals on Wheels organization actually pet food program where they supply pet food in addition to human food, and apparently it's more easy to solicit donations for that program than some of the other programs.
Then there is a well-established study using PARO, the electric seal. If a patient with Alzheimer's patient receive an electric seal, which has a fluffy fur on it, and then like eye moves, like robot eye, but it moves, then they experience fewer agitations. So that is other evidence to alleviate psychological stress among dementia patients.
So real pets and electronic pets. That's terrific. Well, I just wanted to wrap up the last 2 minutes by thanking again the sponsors of this series, ACL, the CDC, HRSA, HRSA, and the National Institute on Aging. If anyone watching the seminar or the webinar is interested in finding out more information about any of those agencies, the point contact people are here on this slide. And thank you again for joining us today, and thanks for all of our speakers.